Hypertension. Defined as a rise in blood pressure of unknown cause that increases risk for cerebral, cardiac, and renal events. In industrialized countries, the risk of becoming hypertensive with blood pressure 140/90 mmHg during a lifetime exceeds 90%. Hypertension usually clusters with other cardiovascular risk factors such as aging, being overweight, insulin resistance, diabetes, and hyperlipidemia. How to prevent hypertension? Lifestyle changes can help lower high blood pressure and can help anyone with hypertension. Many who make these changes will still need to take medicine. These lifestyle changes can help prevent and lower high blood pressure. Do. Eat more vegetables and fruits. Sit less. Be more physically active, which can include walking, running, swimming, dancing, or activities that build strength, like lifting weights. Get at least 150 minutes per week of moderate intensity aerobic activity or 75 minutes per week of vigorous aerobic activity. DO strength building exercises 2 or more days each week. Lose weight if you're overweight or obese. Take medicines as prescribed by your healthcare professional. Keep appointments with your healthcare professional. Don't eat too much salty food. Try to stay under 2 grams per day. Eat foods high in saturated or trans fats. Smoke or use tobacco. Drink too much alcohol. 1 drink daily max for women, 2 for men. Miss or share medication. Reducing hypertension prevents heart attack, stroke, and kidney damage, as well as other health problems. Reduce the risks of hypertension by reducing and managing stress, regularly checking blood pressure, treating high blood pressure, managing other medical conditions, reducing exposure to polluted air. Pharmacological treatment. Initial drug therapy, deciding whether to start with 1 drug or 2. In general, patients with a systolic pressure 10 to 20 mm of mercury above goal and/or a diastolic pressure 10 mm of mercury above goal should have antihypertensive drug therapy initiated with low to moderate doses of 2 agents with complementary mechanisms of action. Some experts begin with 2 agents in patients with stage 2 hypertension, i.e., systolic pressure greater than or equal to 140 mm of mercury and/or diastolic pressure greater than or equal to 90 mm of mercury. Whereas other experts would initiate therapy with 2 drugs in patients whose systolic pressure is greater than or equal to 150 mm of mercury and/or diastolic pressure greater than or equal to 90 mm of mercury. Combination therapy lowers blood pressure more than monotherapy and increases the likelihood that target blood pressure will be achieved in a reasonable time period. In patients with stage 1 hypertension, systolic pressure 130 to 139 mm of mercury and/or diastolic pressure 80 to 89 mm of mercury, who are selected for drug therapy, we initiate antihypertensive therapy with 1 agent. In addition, some but not all experts start with monotherapy if the systolic blood pressure is 140 to 149 mm of mercury and the diastolic pressure is less than 90 mm of mercury. Patients selected for monotherapy. In patients selected to initiate antihypertensive therapy with 1 drug, we select from among the following medication classes: angiotensin converting enzyme (ACE) inhibitor, angiotensin receptor blocker (ARB), calcium channel blocker, thiazide diuretic. Patients selected for combination therapy. Patients selected for initial combination therapy. When 2 drugs are used, they should be from different antihypertensive drug classes. In most patients, the drugs should be selected from among the 3 preferred classes, i.e., ACE inhibitors, or ARBs, calcium channel blockers, and thiazide diuretics, ideally a thiazide-like rather than a thiazide-type diuretic. Note: as noted above, when a thiazide diuretic is used, we suggest selecting a thiazide-like diuretic, chlorthalidone or indapamide, rather than hydrochlorothiazide. Chlorthalidone and indapamide are significantly more potent antihypertensive agents than hydrochlorothiazide, a thiazide-type diuretic, at similar dose levels. Patient with diabetes. Patients with diabetes, nearly 80% of individuals with diabetes have hypertension. The approach to antihypertensive drug selection in those with diabetes has changed substantively over time. The choice of antihypertensive agents in patients with diabetes is based upon their ability to do the following: prevent mortality, prevent adverse cardiovascular events, such as myocardial infarction, stroke, and heart failure, Prevent the progression of kidney disease, if present. Role of patient race. Although some experts choose different drug classes for monotherapy in Black patients as compared with other patients, it is reasonable for clinicians to choose a consistent therapeutic approach regardless of race. There is substantial variability in the blood pressure response to drugs such as ACE inhibitors within self-identified Black or African American patients that is larger than the variability in blood pressure response between Black and white individuals. The preference for a calcium channel blocker or a thiazide-like diuretic as monotherapy in self-described Black patients emanates these drugs have superior blood pressure lowering efficacy and superior protection against cardiovascular events, compared with ACE inhibitors or ARBs. Pregnancy. In patients who could become pregnant and who require antihypertensive drug therapy, we typically initiate a dihydropyridine calcium channel blocker, e.g., nifedipine extended release or amlodipine. If additional agents are needed, we use thiazide-like diuretics, e.g., chlorthalidone, and certain beta blockers, e.g., labetalol, carvedilol, metoprolol. Algorithm 2. ACE inhibitors and ARBs are avoided in this setting because of potential teratogenicity. Resistant hypertension. Resistant hypertension is defined as blood pressure that remains above goal in spite of concurrent use of 3 antihypertensive agents of different classes, or as blood pressure that is controlled with 4 or more medications. One of the medications should be a diuretic, if tolerated, and all should be prescribed at maximum recommended, or maximally tolerated, antihypertensive doses. Approximately 3% of patients with resistant hypertension cannot be controlled, called refractory hypertension, despite maximal medical therapy.